And we have one more talk before we get our break for lunch. We are again in for another treat. We have Dr. Powell who's joining us. And for those who haven't been fortunate enough to be taught by him, he is an illustrious educator and just, I think, probably has taught virtually all the doctors in the greater Seattle area, if not significantly larger geographic area. So I think Dr. Powell is pulling up his slides, and we will have him for actually after lunch too for the rest of the afternoon. I don't think there's, again, I don't think I could give a sufficient introduction to you, sir. So I will turn it over whenever you are ready.
Thanks, Samantha. I feel for all of you as you have to sit and listen to me for 6 hours. So bear with me, and I'll try to really hammer home things I think are very, very likely to show up on the boards. I have a few things that I think are really useful to know that may be a little bit late breaking in these talks, but the vast majority are established things. And board questions have to be written about a year and a half to 2 years pre-tested and everything. So things that just happened in the last 6 months usually are not going to be put on the boards. So we're going to start before lunch. We're going to do a really talk about some dermatology issues and have lots of questions for you. A 39-year-old man presents with a painful rash on his shins. This has been present for the last 2 weeks. He has also had ankle pain and fevers. I'll show you a slide. And so I want you to think about some tests here before I show you the slide, and then I think we're going to bounce into the audience response. So this person we get chest x-ray, blood cultures, ANA, SED-rate, or CBC, and this person who wobbles in with painful rash on his shins, and more importantly, also has severe ankle pain and fevers. Here is what it looks like. Here's what it looks like, and our choices as we review them are chest x-ray, blood cultures, ANA, SED-rate, or CBC. Okay, so the right answer here is get a chest x-ray, because this patient likely has Lofgren syndrome, which is a acute form of sarcoidosis. And the real tip-off, I showed you a picture of erythema nodosum, which is associated with many diseases, but the bilateral ankle arthritis, ankle swelling, somebody with inflammation in both ankles and no other joints really shouts at the possibility of Lofgren syndrome. So that's kind of the distinguishing feature here, whereas erythema nodosum is something that's not a very uncommon thing. We see it linked with a lot of different problems. And if we kind of look through what the etiology is, certainly can be seen with sarcoid, inflammatory bowel disease, can be a drug reaction. It's something can be seen after an acute antigen presentation like strep, primary TB, cocci, and about 30 to 40% of people with enodosum are idiopathic. We never really come up with what the trigger really was. But this case, the thing I want you to take home is bilateral ankle swelling, inflammation, arthritis, no other places on the body. Think about sarcoid. So this person had Lofgren syndrome. He had a fever, he had erythema nodosum, and he had the bilateral ankle arthritis. The chest x-ray will seal the deal because these patients will have bilateral hilar adenopathy. When we treat erythema nodosum, NSAIDs work pretty well. Prednisone's the best treatment as far as making the patient comfortable quickly. And potassium iodide works, but it's really not well tolerated. It's kind of interesting in that it's very targeted and works for this one indication, but most people get really GI upset with that. So I think you'd stick with an NSAID or giving them a short course of prednisone to try to help their discomfort. A 29-year-old woman presents with a rash on her hands and arms. She reports similar episodes 4 other times in the past 18 months. What is the most useful intervention to help prevent further episodes? So this woman has this rash that has popped up, and the key thing about this rash is that it has happened multiple times before. It's not just the first time it's happened. So I think we're gonna have a little trouble because we kind of click pretty quickly to the live poll, and I'm not sure they know what A, B, C, D, and E are. So the answer here is we want to put this person on acyclovir because they have recurrent erythema multiforme. As a result, you see the target lesions here. You can see target lesions here. Very classic for erythema multiforme. And most erythema multiforme is due to a drug reaction. But when you get it more than once, it's usually an infectious trigger. And in adults, that's usually HSV. So if somebody keeps being bothered by this, we will put them on prophylaxis for HSV. So acyclovir would be the right answer here. In children, about half of the time that they get E. multiforme, it's an infection, with mycoplasma being one of the more common infections in children that do this. In adults, HSV is the most important. And then the most common allergic drugs there are: penicillin, dilantin, and sulfa. This will pop up later in the talk. These are very higher likelihood for getting a skin reaction, and certainly a higher likelihood for erythema multiforme. A 35-year-old woman presents with back pain. On exam, you see this finding. So this is what you see as far as the skin on her, and she'd come in with some back pain, but now she has a skin finding too. What would be the most appropriate next step? Check an ANA, check anticardiolipin antibody, start prednisone, check hepatitis C antibody, or come up with an effective treatment for back pain. Which of these would be the most appropriate next step after you see this rash? So this is kind of an interesting clinical thing. I've seen it, I think, probably 4 or 5 times in my career. And what this person has is something called erythema ab igni, and it's from a heating pad that she is wearing. And so the right answer would be a more effective treatment for her back pain, so she wouldn't have to have a heating pad on it all the time. We really want to avoid heat here. So this is not associated with this rash here is not associated with some weird underlying rheumatologic disease. It looks a bit like livedo reticularis. And so some of you may have been thinking, checking an ANA or something like that, because livedo reticularis can be seen with lupus. But these are thicker, they're much larger and a thicker pattern that we see with this erythema ab igni. This translates from the Latin redness from the fire. It occurs with heat exposure. Heating pads are common, hot water bottles, space heaters. It's also been described with laptops when people lay them on their lap, or they put them on, an exposed skin area. They get chronic heat exposure from that, and that can be a real problem. Here is a picture of erythema ab igni from somebody who was using a laptop all the time. Here is livedo reticularis to give you an idea of it's a lot finer. It's very similar in appearance, but it doesn't have the thickness that you see with erythema ab igni. A 46-year-old woman has noticed a painful lump for the last week. She's had the lump for over a year, but this has been the first time she's noticed any discomfort. So this has been a lump that's been there for a while. Now it's uncomfortable, and here's what it looks like. So it's been around for a year, now it's uncomfortable. What do you recommend? Trimethoprim sulfa, cephalexin, schedule excision, or topical mupirocin? Yeah, the right thing is to excise this uh, inflamed epidermal or sebaceous cyst. And so these things can rupture, and then they cause remarkable inflammation. So the patient may have it for a long time, be asymptomatic, and then it can be red and sore. And the first thought we often have when we see something red and sore is it must be an infection. But there really is not a role for antibiotics here, as you folks jumped all over. And we just want to get this out. If it's going to take weeks to months to schedule an excision, you could IND this. You could just drain it, and that would help with discomfort. The problem would be is you're going to probably end up leaving some of the cyst behind and it will reform. So actual excision is probably a better way to go. So epidermal cysts are usually asymptomatic, and we don't need treatment unless the patient doesn't like the cosmetic appearance. If it's on the face or somewhere that's bothersome for them, they can get them removed for cosmetic reasons. When they get really, really sore and inflamed, that might be a reason for removal for these things, and excision is probably the better option. A 60-year-old man presents with increasing redness and discomfort in his leg. He reports pruritus for the last several months and redness with minimal swelling. He has not had any fevers or chills. What is the most appropriate therapy? And I'll show you the picture here. So this is what his leg looked like. So it's been itching, it's been swelling a bit, no fevers or chills. What do we do? Cefazolin, trimethoprim sulfa, vancomycin, triamcinolone ointment. Yep. People really appropriate are going with triamcinolone ointment here. I will tell you that during my residency, I would get one of these admitted every other call night as a cellulitis because people see the redness and the assumption is that this is going to be a cellulitis. And the thing that helps us with this is how, as we go through the picture again, first of all, if it's bilateral, it really helps you. If both legs look like this, you're not going to get bilateral symmetric cellulitis. But you see all this scale here. You see just, it's not a leading edge of redness. It's the whole thing is just kind of a little swollen and red, and he is extremely itchy. That's very, very, very typical of stasis dermatitis like we see here. Both cellulitis and stasis dermatitis respond extremely well to leg elevation. So if you put this person in the hospital, elevate his leg, the next morning he's going to look good, and we're going to pat ourselves on the back and say, hey, that antibiotic did a lot. Really, it's just affecting the stasis by elevating the leg that helps. And with cellulitis, getting rid of some of the swelling by elevating the leg will also help what that can look like too. So this is stasis dermatitis. Here's another picture of stasis eczema where you can see kind of the dry skin, the cracking, the bit of redness there as well. This occurs on the lower extremities at the ankle to kind of the mid calf is sort of the classic area. Pruritus is the standard symptom. And what we want to do is treat the underlying venous stasis with compressions, compression socks, leg elevation as best they can, and then using a mid-potency steroid cream for several weeks to try to help with the itching and the redness and the irritation. Here's another form of dermatitis that we see in the lower extremities all the time, especially in our patients as they get older because their skin gets drier. As we get older, we lose the effective oil glands throughout our body, and our oiliest places are top of our head. The least oily place are from the knee down. And so we see this extremely manifested on the lower extremities. And you can see here a lot of drying, you can see some cracking, and you can see some irritation and redness. Key thing with this is giving them emollients, number 1, 2, and 3 on the list. You can give them a mid-potency steroid to help the itching and help some of the irritation, and doing that for a week to 10 days can be helpful. The other thing that's really important with this eczema crackulae or steatotic dermatitis is to check into them about their bathing habits. Some of these folks sit in really, really hot bathtubs that's going to leach out all the oil, or they take frequent hot showers. So reducing the frequency of bathing and reducing the temperature of the water they're using can be helpful. Another thing that's quite common that we see is dyshydrotic eczema, which causes these little bumps on the sides of the fingers. Sometimes you look at this and you might say, oh, this kind of looks like blisters. Could this be herpes zoster? Could this be some other infection like a fungal infection? Could this be some other blistering disorder like pemphigus or pemphigoid or something like that? And no, the location on the sides of the finger is a real tip off to this. The differential here might be If somebody has tinea pedis and has involvement with a hand as well, that might be in the differential. But the vast majority of patients you're going to see with these little itchy blisters on the sides of their finger is dyshydrotic eczema. These can be extremely pruritic, and they need a little more potent steroid to treat because the skin on the fingers and hands and feet tends to be thicker. So we tend to use generally a high potency steroid for a short period of time. If it's really not responding, you can use an occlusive dressing for a day or two to try to kickstart the treatment for this. Okay, your patient is asking for a refill of her topical metronidazole for the treatment of rosacea. She describes having very dry skin with this, and you can see here the skin looks a bit dry. You scan the list of different options. Which of the following is the best thing to give her to treat her based on all the information you have on her? Metro lotion, 0.75%, Metro gel, 1%, or Metro cream, 0.75%. Which of these would be the best to give her? So I think we're kind of split here, and between using Metro Gel and Metro Cream. And the right answer here is the Metro Cream. And the reason for that is she is concerned about dry skin in addition to her rosacea. And we're going to talk a little bit about the different vehicles that dermatologic preparations come in, but the cream is going to be more moisturizing. The gel and the lotions can be more drying. So they should have similar efficacy, but we're going to have a better outcome if we use the cream as far as the dryness. So when we look at the different vehicles, gels are very drying because they have a very high alcohol content. Because of this alcohol content, they can be quite uncomfortable if somebody has a oozing lesion or an open lesion. Lotions can also be drying because they have alcohol and water content that can evaporate and cause problems. Creams are a mix of water and oil with preservatives. They're much more lubricating than lotions. Um, they can be very, very, very helpful in patients that have dry skin. Ointments are wonderfully occlusive. That's really their main positive, is that they provide kind of an occlusive dressing on this because there's little or no alcohol. They're very lubricating. They're very helpful in open dermatologic conditions because they are not painful. Now, the biggest problem is that they're kind of oily and people don't like that. So that when people use them, they feel that they kind of get oily stuff all over everything. So patients gravitate more to creams or possibly gels than they do ointments. But the ointments have a role when you want something a little more occlusive with a little more potency, and certainly in irritated areas. Foams, shampoos, and solutions we put on the scalp. These are much easier to get on the scalp than trying to put a cream or an ointment on scalp lesions. They're easier to massage into the scalp. You are seeing a new patient. He has a history of atopic dermatitis behind his knees and wrists. He's been using lubricating creams. He's requesting a stronger treatment for flares. So he's appropriately putting some lubricating creams, but as you can see, having quite a bit of activity with his atopic dermatitis. So the question for you is, which of these would you prescribe? Hydrocortisone 2.5 BID, tacrolimus 0.1% BID, clobetasol 0.05% BID, or triamcinolone 0.1% BID? We got quite a mix here. Um, So the result here is that 25% chose D, triamcinolone, 0.1% BID, which is the right answer. What we want to use here, if we can, is a mid potency. If they don't respond to that, you could go up to a very short course of a higher potency steroid like clobetasol. But I would start with the mid potency steroid here. So when we think about potency, we need to know the different classes of steroids. I think it's good for all of you to have a high potency steroid that is your go to, a moderate potency steroid that's your go to, and a low potency steroid. You don't need to know all 48 different steroids that are available. They're very, very similar within class. You also want to think about what vehicle you're going to use. As we talked about, ointments are a little more potent, they're good for irritated skin. Gels can be good in certain areas. So you're going to think about the vehicle, and then you're going to try to know what are your generics that are cheap. Not all generic dermatologics are cheap, but knowing what high potency is the cheapest one, what moderate potency is the cheapest one, and what low potency is the cheapest one. And there's some real differences between pharmacies. Some pharmacies can charge double what the others do for some of these dermatologic products. So if the patient comes back and says, this generic you said was going to be cheap is really expensive, they may want to look at a different pharmacy. So let's just go through the different classes here. Class 1, clobetasol is a great example of that. Betamethasone is the other very commonly available high potency steroid. These tend to be fluorinated steroids, and they are very, very potent. And so we use these for the shortest amount of time. If we go to sort of a mid potency, sort of a class 4, triamcinolone ointment or cream is our real go-to there. And then low potency hydrocortisones, 1 or 2.5%. And patients can get the 1% hydrocortisone easily over the counter. And part of that is because it has the least risk to the patient of overuse. Patients, we give them steroids and they'll keep using them often longer than we tell them to do. We're going to talk in just a second of the complications of steroids, but we want to try to limit how much we give our patients, make them get a refill for some of these so we can keep them to the number of weeks that we want to use for these things. Occlusive dressings are wonderful when you have a really, really bad flare and you want to jumpstart them, where maybe for 1 or 2 days they use an occlusive dressing, particularly at night when they put an ointment on their hands or they put them on their arms. Saran wrap is sort of the cheap way to go with inclusive dressing. If they don't have a latex allergy for the hands, they can put latex gloves on that can work very, very well as an occlusive dressing. We don't like using occlusive dressings on the face or in intertriginous areas because those tend to have very thin skin and are at high risk for some of the complications of the skin getting too thin fairly quickly. High potency steroids, if you're going to use an occlusive wrap or dressing, really try to use it only for a day or two because there can be some significant absorption when you use an occlusive dressing. I think this is a really wonderful rule of thumb. Consider the length of use to be the same number the class is. So if you give a class 1 or 2 steroid, 1 to 2 weeks is your length of use, and maximum you want to be under 1 month. Class 1, less than 1 month. Maximum, ideal 1 to 2 weeks. So you just touch them with a high potency steroid. The mid potency classes, for example, 4 and 5, triamcinolone being the poster child of that class, 4 to 5 weeks is the standard length of use. Keep it under 3 months. And then classes 6 to 7, low potency steroids, length of use 6 to 7 weeks. Keep it under 3 months. A lot of our patients will come in using this chronically because they can get it over the counter. And again, this is the least likely to cause stria, one of the complications of skin thinning. The other major complication is on the face where people will get the thinning and they may not get stria, but they will get blush. You'll really be able to see the redness will come out because the small vessels will be closer to the skin and the patient will have sort of a perma blush if they use a high potency steroid in their face for a while. A 55-year-old Black woman has concern over hair loss. She has noticed hair loss over the last 5 years, and for many years has noticed that the hair on the crown of her scalp was thinner. She does not have any pain, has not had any inflammatory lesions in the past on her scalp. So she's concerned because she's lost a considerable amount of hair. And here's a picture. So you can see there's a lot of loss of hair here right on the crown. What is the most likely diagnosis? Cutaneous sarcoid, CCCA, androgenic alopecia, discoid lupus, or traction alopecia. So which of these is the most likely cause for this pattern of hair loss in this patient? So the right answer here is B, CCCA. And I came up with this question. I wanted to share it because I feel like this is a pretty common cause of hair loss in Black women. And most of us have never heard of it. And I just thought it was an important thing for us to highlight and look at. I think it certainly could show up on the boards, but I think more clinically, something I've certainly seen over the years, and up until about 10 years ago, I'd never heard of this thing before. Central centrifugal cicatricial alopecia. The hair loss is primarily central. It's on the top of the scalp, and it's not really clear why it is. There is a hereditary component to it, and early treatment with steroid injections, topical steroids, can be helpful. So this is one of those things that we just kind of want to recognize or know and be able to get appropriate care to the patient. A 22-year-old woman presents with severe anal pruritus. She reports an 8-week duration of worsening symptoms. She is having problems sleeping because the pruritus is so bothersome. She's tried Preparation H, Anusol, triple antibiotic ointment, and 1% hydrocortisone with zero improvement in the pruritus. Um, her physician recently treated her with a 2-week course of miconazole just to see if this might be a yeast infection, which it isn't. So got that. So here is what the picture is, and this is what the lesion looks like, this incredibly pruritic lesion that has been really not responding to treatment. What is the most appropriate therapy? Fluconazole for 3 weeks, mupirocin, ciprofloxacin, clobetasol ointment, or stop all therapies? Okay, so the right answer here is D, is clobetasol. And this kind of goes against everything we teach you, which is we got to be careful, like in the genital area with high potency steroids, anal area maybe, intertriginous areas, we kind of like generally err towards low potency steroids. But for this entity, it responds really only to high potency steroids. So lichen sclerosus is much more commonly seen in women, and 80% of them are genital or anal. So this area, it's you need to be looking for it there and thinking about the differential on lesions there. It can be a challenge, and many of these need to get a biopsy to be sure about them because especially genital malignancies can look fairly similar. It's a chronic inflammatory disorder. It's very, very shiny white atrophic plaques. And we usually use a high potency steroid, and we may have to use it a little longer than we're used to or comfortable with. I mentioned before 1 to 2 weeks. For this entity, we may need to use 4 to 6 weeks of this high potency steroid. Okay, here's another fairly common thing that we run into all the time, and this is somebody with contact allergy. This is an individual, a patient of mine, who wanted to know what was going on with the rash on the right arm, and then they showed me both their arms, and you can see there's a little bit of a rash developing on the left arm because they just switched their watch from their right side to their left side. And so this is where the watch was hitting. Now it's hitting here and it's starting to bring out a rash here. So this is due to nickel allergy, and most metal allergies that you're going to run into are nickel allergy because most metals have a little bit of nickel in them. So when somebody says they have a gold allergy or they think they have a silver allergy, it's usually going to be a nickel allergy. This is an individual with poison ivy contact dermatitis. Blisters are a very, very, very common part of contact dermatitis. So these can be very weepy, blistery lesions. This is an individual who is reacting to the clasp here. It's rubbing back and forth on the neck, and it's again probably a nickel allergy. I think thinking of contact allergy when we see vesicles because they frequently blister, and when we see odd shapes, things that aren't typical shapes, we see triangles, we see rectangles, we see things that would make sense that could be something at contact against it. And then especially when we see one area involved that makes a lot of sense that area got contact. Most common offenders for contact allergy are nickel, latex, poison ivy, poison sumac, and then some lotions. Lotions have a lot of things mixed into them. They have fragrances. Um, Probably the most common thing I've seen as far as contact allergy, as far as something people put on, is Benadryl cream, which has about a 2% contact allergy rate. And that's a mess because they come in itchy and then they have itchiness and then they put the cream on it and then they come in with blisters, and we can easily miss the diagnosis if we don't ask them what they put on it. We may not always figure out why they first itched, but we can figure out why they're blistering now. Another thing that is very common to cause contact allergy are patches. This is an individual who had a nitroglycerin patch on and reacted to it. Very common to have a reaction to estrogen patches. And then the adhesive that is used for ECG leads is not great for the skin. And it shouldn't be a huge problem, except I don't know why my patients seem to want to leave the emergency department with their ECG leads in place. I don't know if they think that that's going to prevent them from getting chest pain again, or if they do, they can get the EKG hooked up really quickly. But I have seen a couple of patients of mine come in with pretty bad contact allergy around the leftover ECG lead that they've left on because of the effect of the adhesive. Here's an interesting clinical situation. This is a patient who has a fixed drug eruption, and you can see how round and dark color the lesion is. And fixed drug eruptions tend to be very, very circular. They can be quite large. They can be 3 to 5 centimeters, is sort of the typical size for it. Most patients only have a few of them on their body. They may have anywhere from 1 to 3 or 4 of them. They may only have it in one place. And an interesting thing about these things is if you diagnose it, for the example, this patient has it on their, on the cheek, and you stop the drug, eventually over many months it will fade. But if the patient takes a drug again, they may get it again, and they probably will get it right back in the same location. The other odd thing about fixed drug eruptions is that they tend to be more common on the genitalia compared to surface area on the body. So patients may come in with a round circular lesion, for example, on their penis, and then they think they have an STI. So just be aware that fixed drug eruptions are a few round lesions and they can occur anywhere, but that they do have not infrequently show up on the genitals. So 3 to 5 centimeters, red to purple, sharp borders, the same antibiotics, the same drugs I mentioned before, penicillin, sulfonamides, dilantin, are very allergic on the spectrum of different drugs we give out. But the reality with fixed drug eruptions are that they happen with almost every drug. For many drugs, they're very uncommon, but you're going to see them related to common drugs like SSRIs and statins because those are so commonly used with millions and millions of people on them. Even a really rare event like a fixed drug eruption with them, you may see more commonly than you do with say, a drug like dilantin, where it might be more likely, but you don't have as many patients on dilantin. A 29-year-old woman comes to the clinic for evaluation of a facial rash. She has had this problem for the last 6 months. She's tried several over-the-counter cleansers and natural products without any benefit. Let's show you what the rash looks like. So here's the rash. You can see it here. Pretty good example of it here. You can see some of it here too. So what would you recommend? 0.75% metronidazole gel, hydrocortisone 1%, desoxymetasone, ketoconazole, or benzoyl peroxide. Which of these would you recommend for her? So this is a patient with perioral dermatitis. And this patient, probably the best first start of what we give you choices here would be metronidazole gel. A topical antibiotic is sort of the first line therapy for this. What we want to avoid in these patients is steroids, and especially more potent steroids, because they can actually make the problem worse. And these patients will usually come in with a history saying, I never had acne when I was a kid, and now I'm, 29, 35 years old. Why am I getting it now? Why am I getting these red bumps? And they're just usually on the chin, they're right around the lips. You can also get a very similar entity around the eyes or, periorbital dermatitis. So onset usually between about, really the peak age about 25 to 40. Lesions around the mouth with sparing around the vermilion border. They start out with a little erythematous bump, then they become scaly, and topical antibiotics are really a good option. If that doesn't work, then treating them like we treat acne with oral antibiotics is the next step. The 25-year-old man presents with a rash, which I'll show you. He's tried over-the-counter hydrocortisone cream without any improvement. The rash has gotten worse over the last 9 months, despite using the hydrocortisone cream. It's now affecting his scalp and his axilla. So he's been using treatment, and this is getting worse despite treatment with topical hydrocortisone cream. So, what would you recommend to do as your next step here? Get a CBC, an HIV test, imaging of the SI joint, or possibly light therapy, topical antifungal or light therapy. So the right answer here, I think, is checking an HIV test because this person has somewhat refractory seborrheic dermatitis with using appropriate treatment on his face, not getting any response. And most sebderm will have a pretty good response to a type of topical hydrocortisone. Having had the experience of seeing a lot of patients during the height of the AIDS epidemic, when we saw so many patients coming with AIDS, 90% of them had seborrheic dermatitis. And we would frequently see people with refractory sebderm that would do standard treatments and they would still have a lot of sebderm through it. So just because we didn't see a normal response here, making sure that they've had an HIV test. If they had one a year ago, I wouldn't repeat it because this is associated with low CD4 counts. The exacerbation of sebderm doesn't happen as an early manifestation. So if they've had testing in the last couple of years, you don't need to do it. But if they have never had a HIV test, would definitely get one in this patient as the next step. So sebderm onset is usually in the 30s to 40s. It's usually going to continue. Patients can use treatments and get it under control, but if they stop treatments, it will usually come back. The two diseases to know that are associated with it are HIV disease with low CD4 counts and Parkinson disease. Patients with Parkinson's disease, it gets worse as the disease progresses as well. So, you got an 80-year-old who pops up with sebderm, never had it before, and it's problematic. Relook at the patient and think, could this person have Parkinson's disease? It likes hairy areas, so you see it in the scalp a lot. You see it right around hairy areas, and it loves the nasolabial folds because it likes very oily areas, and that's about the oiliest area on the body. The best treatment is probably ketoconazole shampoo. Using an antifungal shampoo will help with the dandruff that occurs with this, and then they can wash their nose and face with it. Using that 2 to 3 times a week is quite effective. If that is not effective or they break through even with that, then using a 1% hydrocortisone cream on the face is an option. You can also use topical ketoconazole, which can be effective as well. Um, if they have more, if they continue to have problems, making sure that they're using the shampoos at least weekly or a couple of times, a month, just to get maintenance therapy in there. And then if the patient doesn't respond to anything, then we can go to things such as systemic antifungals. We can try calcineurin inhibitors. We can try combinations of all of those. But I think you're all aware and have had a lot of experience treating this. Most people respond to the antifungal shampoos and the 1% hydrocortisone. A 45-year-old woman has been bothered by facial redness and flushing for the last 2 years. She has not gone through menopause yet. She has tried several natural products which haven't helped. She saw her physician who prescribed topical metronidazole for her, which has only been minimally effective. So she's been treating it with topical metronidazole without much benefit. Here's what she looks like. What do you recommend? Oral doxycycline, topical benzoyl peroxide, topical clobetasol, topical bromonidine, or topical isotretinoin. So which of these would be the most effective? So this is a person with acne rosacea, and the key thing on this patient is that they have a lot of flushing. They're having a ton of flushing. And unfortunately, metronidazole gel, metronidazole creams, the oral antibiotics don't do much for flushing. So we would need to do something for the flushing. And of these choices, bromonidine is the best choice for flushing. Of these four choices, it actually is indicated for patients with acne rosacea who have a lot of flushing. So a couple of words about acne rosacea. It's more common in women, sort of coming on between the ages of about 30 and 40. Fair-skinned individuals are more likely to have it. It's very common in individuals with Celtic Northern European heritage. Sun-damaged skin is at highest risk. We especially see it mostly on the face, and it's a mix of erythema, flushing, papules, pustules, and telangiectasias. I want you to remember the flushing part of this because individuals with acne rosacea can flush from about the mid-chest up. It's not just the face that flushes. So they may tell you they think they have total body flushing because they really notice it in the upper part of their body. And it's probably the most common cause of flushing in patients who have recurrent flushing. Treatment, we want to do photoprotection because that's a trigger. Um, Camouflage makeup can be helpful in people that have the blush. If they have a lot of papules and pustules, the antibiotics work very well. Metronidazole gel, azelaic acid, even topical ivermectin can be helpful for this. In patients who have severe disease and not in refractory, oral doxycycline is good. But for those with the erythema and flushing, topical bromonidine and oxymetazoline are very, very helpful. And the cheap option you have is doing a quick trial with the oxymetazoline because that is the active ingredient Afrin. They can buy some of that. They can splash a little bit of it on their face, see if the redness gets better. We don't want them to continue to splash it on their face because it's a little bit too much for them and that might cause rebound. But what they can do is they can mix the oxymetazoline in with something like Eucerin cream and do their own compounding on that and use that. I'm going to skip that. A 35-year-old man presents with a 3-month history of rash. The rash has not been pruritic. He has not been on any new meds. He's taking an allopurinol, sertraline, and omeprazole. What is the most likely diagnosis? And here's the rash. So what's the most likely diagnosis here? Tinea corporis, drug reaction, eczema, tinea versicolor, or a viral xanthan? So you did well on this, tinea versicolor, and this can be sort of a little bit of a confusing picture of it, but this is one of the most common ways that it presents. So what you see here is widespread rash. So it's really everywhere on the back. And you see dark coalescing round lesions. And when an individual has a real eruption of tinea versicolor that's pretty impressive, these round lesions can kind of come together. This is sort of a typical Seattle person, never sees the sun. So what we aren't seeing here is the other pattern that we can often see with this, which is the hypopigmented spots that can occur where the lesions are. So this is an individual who gets a tan, and you can see that they have these hypopigmented lesions when they're out in the sun. That's where the name versatile color comes from, versicolor, that sun exposure, they'll be hypopigmented. No sun exposure, they will be red to sort of a light brown. If you scrape these, they will be positive, much more than scraping other scaly lesions where we might have a mild tinea corporis or something. Tinea versicolor is just teeming with budding yeast and hyphae. So you will see it. You're not going to miss it if you scrape it. As far as what it's caused by Pityrosporum furfur, which is really a yeast form, causes these round lesions. And the key thing about this is location. It's really on the chest and back. It rarely is on the legs below about the mid thighs, and it rarely, if never, occurs on the face. So this is something you're going to see on the chest and back predominantly. Exposed to sun, it will get hypopigmented. Ketoconazole shampoo works great for this. Selenium sulfide shampoo is very effective. They do need to put it on and let it dry a little bit in the shower for, 3 to 5 minutes. So some people don't like that. They don't want to get cold in the shower where they kind of step back and let this stuff have some contact time with the skin. If they don't want to use a topical, you could use single dose fluconazole, which has been studied and can be effective. We do have to use a bit of a higher dose of fluconazole. Usually the single dose fluconazole isn't going to get us into too bad a long-term drug interaction. Single dose fluconazole generally can be used for some of the drugs it interacts with because it doesn't build up a long-term high level. Okay, we're just going to go through this quickly, and since we don't have a lot of interaction here, I do want you to think in your mind what this is as I show you pictures again of things that we've shown you. So this is erythema multiforme here, the target lesions. And remember, the key point is if it's recurrent, think of underlying HSV infection. This is what we just showed you, tinea versicolor. These are individual round lesions. We don't see any coalescence here. Here is seborrheic dermatitis, and I want you to think about the two diseases that can be associated with it. If it's severe seb derm, think about possible HIV disease or Parkinson disease. And this is contact allergy, individual wearing bracelets, probably nickel allergy. And the last one here, this is a fixed drug eruption. These, as we mentioned, can be 3 to 5 centimeters across. They are quite round. They may only have one on their body. If they get re-exposed to the same drug, it will probably show up in the same place. And there's a predilection for the genitalia with these. Okay, well, we will stop there and give you a break until 1 o'clock, and I'll be back for the whole afternoon with an onslaught of all sorts of topics for you. I'm happy to handle any questions people have. If they want to put them in chat. Okay, well, if there aren't any more questions or any questions, then I will see you back at 1 o'clock.
Thank you. That was fantastic. I always learn from you.